Chiropractic maintenance care for work-related low back pain, association with disability recurrence. Well, let's look at a study that on the surface is quite positive for chiropractic maintenance care. By delving a little deeper, we can develop a better understanding of what this study does and does not demonstrate. Health maintenance care in work-related low back pain and its association with disability recurrence. It's published in the Journal of Occupational and Environmental Medicine. The authors are Cifuentes, Willits, and Wozniak. This is an interesting and curious study that was just published in 2011. It's the first study to evaluate the recurrence of disability in a worker environment. More specifically, the researchers attempt to determine if there is any evidence for the difference in recurrence when comparing care by an MD, physical therapist, or chiropractor, and for those not receiving maintenance care. Given none of the authors are chiropractors, it is interesting that they seem so acutely aware of the health promotion aspect of chiropractic, the aspect of loyalty of patients, and the lack of uniformity in how maintenance care is carried out. A recent headline states, "Chiropractic works and so can your patients." This news article implies that it's been demonstrated in this study that patients treated primarily by a DC have a recurrence rate of low back pain lower than those treated only or mostly by a physical therapist or medical physician. We'll look at how accurate that statement is as we explore this interesting study. Here are some interesting aspects of this study that we should keep in mind as we review the study design and results. The principal investigator works at the Center for Disability Research at the Liberty Mutual Research Institute for Safety. Probably related is the access to a large insurance company's data that represents 10% of all U.S. workers' compensation coverage. This data was broad in that it covers companies of many sizes across several states and includes a broad array of industry types. This study is the first of its kind in that it looks at health maintenance care for specifically work-related low back pain. The researchers generate a hypothesis on the front end of the article stating that given chiropractors are proponents of health maintenance and that the approach by other providers such as MDs is not focused on maintenance, that the patients with work-related low back pain who see chiropractors should have a lower incidence of recurrence of disability. They in fact use the chiropractically treated group as the reference group for comparison. Let's do the flyover on this study and take a global view first before looking deeper. After exclusion criteria were applied, there were 894 cases of nonspecific low back pain out of 11,420 new cases, followed over a one-year period. One of the main focuses of the study was on provider types at different times, including the disability period, the maintenance period, and also patients that appeared to be loyalists to a particular provider. This was defined as a provider whose treatment comprised greater than 50% of visits for a given patient. Here's how the loyalty factor breaks out with regard to the number of patients. Although there are more chiropractic loyalist patients, it is close to that of PTs. More importantly, the combination of patients who switched or did not get maintenance care is far higher. Not evident here is who patients saw for their disability or maintenance care. It is clear that for the disability period, it was much higher for PTs compared to MDs or DCs. For the maintenance period care, it was for some reason MD dominant with chiropractors last. Interesting. Let's dig deeper here. We'll start with definitions. The initial disability period was defined as total temporary disability where the worker was unable to work. The health maintenance period was defined as the period after the initial disability period ended, and the person had returned to work for at least 14 days. Temporary partial disability was included in the maintenance period and was defined as alternate work and lower wages, but the individual was back at work. Recurrent disability was resumption of at least 15 consecutive days of temporary total disability after an episode of health maintenance care. Time to disability recurrence was the outcome variable for this study and was defined as the number of days between the first day of returning to work for at least 15 consecutive days after the initial disability episode until the day before recurrence of disability. So who were the patients? After some initial exclusion criteria application, the researchers, in an attempt to create a more homogeneous study group, applied even more criteria, including elimination of patients with incomplete data or more than one injury date reported, those with unrelated diagnoses to low back pain, those with an episode greater than 7 days after the initial injury, meaning the disability was given after 1 week as opposed to right after the injury. Those with fewer than 4 visits were eliminated, as were those not between the ages of 17 and 65. Workers represented a wide variety of employment, which was categorized using a classification called O-Net job families. We can see here how this breaks out with regard to the jobs for which the largest group of patients had recurrent disability. Not surprisingly, transportation and material moving, production, installation, maintenance and repair work, construction and fabrication, and buildings and grounds workers had the highest number of patients with recurrence. How often did patients suffer from recurrent disability? For the entire cohort, it was 11%. The researchers broke this down by disability and health maintenance periods and provider type. These are the numbers which favor chiropractic care, certainly during the health maintenance period, with a proportion of patients seeing chiropractors who had recurrent disability at 6.5%, with the highest proportion of patients with recurrence in the PT and MD groups, and the lowest in the no maintenance group. We'll get back to that statement later. Noteworthy is that for the disability period, provider type was not associated with disability recurrence differences. For the 2 periods combined, disability and maintenance, there again was an advantage seen with lower recurrence in both the DC and no maintenance care group and higher rates in the PT and MD groups. These stats can be viewed statistically in a different way using something called survival analysis, and the primary statistical measure used in the abstract of this study, the hazard ratio. Don't get nervous. The general concept is fairly easy to understand. When looking at risk associations, it's probably more common to see risk ratios utilized. However, there are some limitations to this approach, in particular, not including time interval measurement points. Hazard ratios help. My first point, a ratio automatically means that a difference is reflected between 2 comparison groups by a number that is not 1, meaning a ratio of 1 simply means the 2 groups are the same. Survival analysis is a technique used not only to determine who survives in a study, but also can measure the time to an event, such as low back pain recurrence or disability. The hazard in the term hazard ratio varies with the study. In this study, the hazard is the recurrence of disability. Now, using an approach called Cox regression, the incidence rate or number of new cases, in this study the recurrence of disability, is measured for the remaining population per unit time. And for those fond of statistics, this is different than logistic regression, which measures the ratio or proportion or numbers of patients with a condition utilizing odds or risk ratios. Well, what does that mean for this study? At specific time periods, the number of new cases of recurrent disability is measured compared to the remaining group that has not had a recurring disability episode. The measure in survival analysis is called time to event. In this study, the time to event was the time to disability recurrence, which was the primary outcome variable measured. The ratio in hazard ratio is obviously a comparison between 2 groups. The reference group here is the chiropractic group, which is then compared to the other provider types and no maintenance group. This study is so data intensive, it's difficult for the non-statistician to appreciate and comprehend. The researchers attempted to not only measure many variables, but also constructed an algorithmic series of models for the interpretation of the data as demonstrated here. What we will focus on, though, is the stated hazard ratios in the abstract, and here they are. Well, what do these numbers mean? As stated before, an HR of 1 means no difference. The reason the DC hazard ratio is 1 is because this was the referent or comparison upon which other groups were compared. As a general statement, it can be said that the hazard ratio of 2 for the PT provider type indicates that the recurrent disability is approximately 2 times more likely to occur in patients primarily treated by PTs compared to those treated by the chiropractic provider on any given day. More telling here, and a weakness for these hazard ratio estimates, is the range expressed as the 95% confidence interval. Remember that an HR of 1 indicates no difference between compared groups, but the confidence interval range for MD-treated patients is broad and goes below 1, as does the no-maintenance group of patients. An HR below 1 would then contradict the point estimate mean that implies an increased recurrence because a hazard ratio below 1 implies a decreased recurrence compared to chiropractic patients. This is why it's so important to look at the range of values instead of only the mean or point estimate. Now let's look at cost. No surprises here. Cost during the maintenance period is less than the disability period and less for the no recurrence cohort compared to the recurrence cohort. More on that later. Before we hone in on just the chiropositive elements, let's look at some of the limitations of the study and most importantly on what we don't know about what could influence results. There is no measure of how often patients are treated, and specifically for chiropractors, what treatment was rendered. Whether there was manipulation only or combinations of care including counseling or staying active or exercise recommendations. We don't know how much patient choice influences their outcomes, even though the loyalty factor was measured. Most importantly, although the study states the severity is accounted for, we don't really know if this case mix bias affected results. The main concern here is that although covariates were assessed, there is a study contradiction. This study was supposed to be exclusive to patients with nonspecific low back pain, but in the covariate section, the researchers' approach to measuring severity was to use ICD codes that indicated conditions that would likely influence severity, such as patients with spinal stenosis, radiculopathy, instability, or sequelae to prior surgery. Well, this isn't nonspecific low back pain, even as defined by the researchers. This is curious. The researchers do state that prior research has not found a strong association between low back pain severity and return to work outcomes. However, they admit that the complexity of controlling for case mix bias is problematic. For example, healthcare systems may have diverted the more severe cases to MDs. Another confounder not addressed is the strong element of psychosocial factors. The researchers are forthcoming with regard to the limitations of their study. They state, after controlling for severity and demographics, that no health maintenance care is generally as good as chiropractic care. Both are better than medical or PT care, but why? The researchers hypothesized that perhaps like no maintenance care, chiropractic care substitutes for MD or PT care that may carry with that care risks associated with medication prescription or procedures that may influence recurrence. They also hypothesized that patient interaction may be a factor. So we're left with a curious mix of data and uncertain result conclusions. What are we to do with this new information? The researchers should be applauded for this large study and its implications. By not only looking at the relationship between provider and disability recurrence related to low back pain, they acknowledge the potential issue of patient-provider loyalty. And although no clear conclusions can be drawn for why the trend appears, the trend nonetheless is that those seeking chiropractic care for work-related injuries appears to be that they have a lower disability recurrence than those seeking MD or PT care. In the chiropractic group, there were fewer surgeries, less opioid use, and lower costs. These results are certainly preliminary in changing workers' compensation guidelines, yet it creates a research agenda item, which is to see if this trend holds out in a more controlled environment, and it calls for more research for discovering if there are unique features in the chiropractic management of workers' low back pain that could be utilized in an effort to decrease low back pain recurrence and hopefully disability recurrence.